Good evening, everyone. Welcome to this interactive session. I think Oncology Forum has really made this intersections ho rahe hain on interactive classes by the PGs for the PGs. This is a great platform for everybody to learn and from their peers. So many sessions have been done in this format earlier. So this is the first time that palliative medicine upon. So thank you so much, Nidhi, and all the Oncology Forum, the office bearers, to give us this platform. So the topic for today is prognostication in advanced cancers. I think everybody, all the oncologists do this day in and day out. But probably we sometimes, the whole session, the idea about this session was to create awareness about how do we objectify this prognostication, science of prognostication, and learn more about it with each other. So with this, I would like to welcome Dr. Sushma Bhatnagar. She is my mentor. She is the Chief Oncology in AIMS IRCH, Delhi. And she is, of course, a very senior palliative care physician who has taught, I think, most of us palliative medicine. All of us around have learned from her. So over to you, ma'am.
Okay, thank you, Megha, and thank you, Nidhi. I am so happy to see that today we are starting by the students and for the students classes in area of palliative medicine. And thank you, Oncology Forum, for giving this opportunity. And this is, I know this forum has become, it has become a leading forum all over not all over Delhi, but people are talking about this forum all over India. And this is such a good platform where all the oncologists, we meet together and we discuss the most important topic. And now this also shows that now in at least in oncology, we all have realized that integration of palliative medicine is important. And today the topic which Megha and Gaurav has selected, how to prognosticate patients in advanced stage of cancer patients, I think this is a very important topic, because most of the time people keep on thinking of and that how much to do, when to stop, how to do, how much we should do and how much we should not do, and there are always gray areas. But it is not always true. Now a lot of research are happening, and we can have a clear cut margin or clear cut discussion, clear cut decision making process. And one of the decision making process is learning prognostication. And I'm so happy that the first topic which we have included is prognostication, and the first topic first lecture which will be taken by Puneet, and I think Puneet ke saath Puneet hi le raha hai na Megha first lecture, and Puneet is again one of our brilliant, bright first MD palliative medicine student, and is doing wonderful work in Gangaram Hospital. So Megha, you want to introduce Puneet, or I should?
You can do it. I think you'll do better than me. You know Puneet much more.
So I just want to say that it's like when we started palliative medicine and when we saw Puneet and Nandan, we realized that future of palliative medicine is too good in all over India, because they were the people, those who have really worked hard, and they have created some landmark protocols and policies, and the traits which they have set of hard work and sincerity, I think it's still going on. Now it's 10th, 11th, 12th batch is going on, but whatever they have set, the traits of sincerity, it is still going on in the department. So thank you, Puneet, and I'm so happy that you are taking this lecture. And thank you, Megha and Gaurav, for starting this, and obviously Nidhi, who is always keeping everybody on track and organizing everything and keeping everybody on loop. Thank you. Thank you very much. Start, Puneet. Thank you.
Thank you so much for your kind words. Am I audible?
Volume is a little low, I think, और मेरे लैपटॉप की वॉल्यूम लो है क्या? नहीं, मेरी
little low. अच्छी तरह से बोल.
louder.
Right, ma'am. Yes.
Good now.
Yes. Thank you so much. Thank you so much, Sushma, and for your kind words. So I'll be starting my lecture. I'll just share my screen. Are my slides visible, ma'am?
Yes.
Okay.
पुनीत इसको स्लाइड शो में करो.
Yes, ma'am. थोड़ा टेक्निकल ग्लिच आ रहा था. Yes. So thank you so much. So I'll be beginning my lecture on the science of prognostication. So today I'll be covering the basics of prognostication. The tools will be covered by Avinash. So why is prognostication important? From the past, what we have learned during our MBBS days, that we need to diagnose a patient and we need to treat the patient right till the end, right? But what about the quality of life of the patient? What about the survival chances? What about the prognosis? So later half, we tended to realize that prognosis again is an integral part of the clinical skills in medicine, and it should be developed in all the physicians and should be used in all the specialties, not only in cancer. So what do you mean by prognosis? Prognosis is defined as the relative probabilities of the various outcomes of the natural history of any disease. So what are the reasons to be proficient at prognosis? As ma'am was telling in the start, why is prognosis important? So the reasons are to provide patients and their families with information so that they can set their goals, priorities, and expectations of care, to help patients develop insight into their dying if it is a poor prognosis, to assist clinicians in their decision making, very important, to compare clinical patients with regard to outcomes, to establish patients' eligibility for care programs. Mainly, you have seen that in Western bodies, if the prognosis is less than 6 months, they refer the patient to the hospice programs. For designing and analysis of any clinical trials, we need to know the prognosis. Hence, this is important. And for any policy making, so what will happen if patients are unaware of their prognosis? They are more likely to prefer aggressive care, right? In fact, they are more likely to receive aggressive care. They have a worse quality of life. In fact, they have a worse quality of death, are less likely to complete advanced directives, are less likely to receive care consistent with their preferences. So just imagine the role of prognosis. So what
पुनीत
is,
पुनीत एक
yes,
तो स्लाइड शो करो और एक स्लाइड मूव नहीं कर रही है पुनीत. Yes. Sorry for disturb.
yes, sorry, ma'am.
नहीं ये स्लाइड शो नहीं हुआ अभी भी.
I'm just doing it.
Okay, fine.
Ma'am, is it visible?
नहीं विजिबल तो है बट स्लाइड शो नहीं है अभी भी.
Okay, ma'am, मेरे इसमें slide show आ रहा है. I'll just cancel it and
अच्छा
I'll
लेकिन
change it.
एटलीस्ट मूव तो करो. मूव करो.
I'm just changing my slides. Are they moving, ma'am?
No.
नो
No,
मूव
they
नॉट
can't.
मूविंग.
No.
नॉट मूविंग.
Okay.
पुनीत,
I'll
हाँ,
stop
शेयर
share
स्क्रीन
करवा
हटा
देंगे.
के फिर से करो. हाँ.
Yes, I'll just do a news. I'll just
नो
stop share
प्रॉब्लम.
and I'll
डोंट
change it.
डोंट गेट स्ट्रेस्ड अप. डोंट वरी.
Yes,
आराम.
yes.
2 मिनट एक्स्ट्रा ले लो, कोई बात नहीं। Or you can do one thing, Puneet, you can send slides to me, I will change slides for you.
Yes, I'll just do that.
अभी आवाज भी I will do that. No, don't worry.
I've just tried it once. Are my slides visible now?
विजिबल है पुनीत, बस
Yes,
स्लाइड
visible.
स्लाइड सुनो ये और चेंज
Right,
करके
so
देखो, चेंज करो, ये चेंज भी नहीं हुआ।
Is it working now?
नहीं नहीं,
नहीं,
स्लाइड
नहीं।
तो भी नहीं है, चेंज भी नहीं हो रहा है।
I'm so sorry.
Don't worry, but just send it to
Ma'am,
me.
I'll just mail you.
I will change for you.
If somebody is saying first do slide share and then share your screen, maybe it will work.
Yes, I'll just try that.
Yeah, I'll send it to me or Nidhi.
I've just sent it to ma'am.
Ma'am,
I'll just send it to Gaurav sir.
एक्चुअली में उसको मैंने ऑप्शन दिया था कि मुझे भेज दे, इसलिए उसने आया नहीं है पुनीत, आने दे, नहीं तो जिसके पास आ जाएगा वो स्टार्ट करो उसका। लिटरली
okay,
घबराना
by
मत।
that time, I think our
I have, you can start, Megha.
I-
I have got the slides. I will change it for
okay.
you.
By the time, I'm sorry, but let me also introduce our chairpersons or mentors for the session. So we have with us Dr. Rakesh Garg, who is a professor in onco-anesthesia and palliative care. Sorry, sir, I didn't see that you were around. Hello, sir. You're muted, sir.
Thank you, Megha. Thank you so much.
Sorry, I thought you haven't joined yet. Okay, and Dr. Ankur has also joined us. He is the Director Medical Oncology in Fortis Hospital, Gurgaon.
पुनीत स्लाइड नहीं आई है, अभी केवल प्रोग्राम भेजा है तुमने।
And Dr. Anil Anand has not yet joined, but I think he will join soon. Thank you so much. Rakesh.
Good evening, Dr. Megha.
Yeah, good evening.
Good evening, Dr. Megha. Good evening, everybody. Pleasure to join.
Thank you so much, Dr. Rakesh and Dr. Ankur. We are really privileged to have you guys as mentors for the session. Great, we had a glitch and we could introduce you in between. Didn't have to stop the slides. Okay. Have you mailed me?
I just resent the mail.
पुनीत स्लाइड्स किसको भेजी है? नहीं आई है
मैम
स्लाइड्स।
जस्ट मैम आपको अभी भेजी है ना?
अच्छा देखो अभी खुल गया तुम्हारा, स्लाइड शो करो।
Ma'am, is the slide so visible at the other side?
No, Puneet, no,
No,
it's
sir.
not there
I'm
somehow.
I'm so sorry. Actually, here it is going on, but that's it. It's not.
So first, make the slideshow, or if the slideshow is not happening, वो reading जो एक वो छोटा सा ग्लास बना हुआ है उसके just पहले वाला जो icon है, that reading kind of a thing,
दीदी,
उस पे
दीदी,
click करके
now I am sharing, okay?
Just stop sharing.
Now you stop sharing, I am sharing, okay? Can you see now?
Yes.
ma'am.
Yes, ma'am.
Yes,
Visible.
Okay, fine. So go ahead. Now whatever you wanted to say, शुरू के बोलो दोबारा से। Sorry.
I'm so sorry for the technical glitch. I'm so sorry. So I'll just start my presentation on science of prognostication. So ma'am, next slide. So during our olden days, what we were taught was to diagnose a disease and to do a treatment. But what about the quality of life of the patient? What about the prognosis? We weren't taught. We were just taught that treat the patient right till the end. Next slide. So after knowing that prognosis is an integral part of the clinical skills in medicine, we now believe that diagnosis, treatment, and good prognostication is equally important in managing a patient as a whole. In prognosis, we need to understand the quality of life and also the other aspects. So now coming to the definition, what is prognosis? Prognosis is defined as the relative probabilities of various outcomes of the natural history of a disease. Next. So why is it important to prognosticate a patient? As ma'am was telling in the start that we need to prognosticate a patient because he has to be an integral part of the goals of care throughout the trajectory. So some important points which we need to remember are to provide patients and their families with information so that they can set their goals, priorities, and expectation of care, to develop patient to help patient develop insight into the dying process if it is a terminal event, to assess clinicians in their decision making, to compare similar patients with regard to outcomes, to establish patients' eligibility for care programs, including timely referral to hospice. As we know in Western world that if the prognosis is less than 6 months, there is a referral to hospice. And also it is very important to design and to analyze of clinical trials. Very important is that for policy making in this in respect to appropriate resource utilization, prognosis is very, very important. What will happen if patients are unaware of their prognosis? They are more likely to prefer aggressive care. What about prefer? It is more likely that they will receive aggressive care. They'll have a worse quality of life. In fact, they will have a bad quality of death. And they are less likely to complete advanced directive. They are less likely to receive care consistent with their preferences. So if we talk about prognostication, we all will be coming up with many questions. Like the patients will be telling us, so how long do I have? So this will be related to the survival or the death. They may ask, sir, how quickly, if the ascites has reaccumulates, how quickly the ascites come. These are the signs of disease progression. So you will have to know that what is the patient or the caregiver asking. Are they asking about the survival? Are they asking about the disease progression? Are they asking about the treatment options? Are they asking about the palliative care options which are there? So many times they will ask you, sir, will I be able to walk again? So we will, this question arises about the domains of disability. Sometimes, and if the pain is very severe, they might ask you, sir, will I get addicted to morphine? So by looking at these questions, we need to realize that prognosis is not just one-time process. It is dynamic process and it needs to be done again and again over the course of a disease, because prognosis is not individualized. It can change from time to time. So it is our duty to prognosticate the patient from time to time according to the performance status of the patient. Next slide. So how do we prognosticate? So the most important thing is to foresee prognostication. That is to formulate a prediction, and then we need to communicate this prediction. So in foreseeing prognosticating sorry in foreseeing the or the formulating a prediction, we need to know about some idea about the prognosis. We should have some idea related to the clinical experience, some idea about related to the statistical tools which are available. Next slide. So, if we talk about formulating prognosis, through prognosis of a disease is static, which I was telling you. Prognosis of individual is dynamic and provisional. So, this can be really divided into two parts. One is your clinical prediction of survival, and second is your statistical estimate of survival. In clinical prediction of survival, this is we use it commonly in a day-to-day practice. The advantage is that it is flexible to use, and we can see and talk about the prognosis in the immediate setting and in the later setting as well. So what are the disadvantages of clinical prediction? If you know, there might be some cognitive biases. There are two very important terms such as framing effect and anchoring. If you talk about framing effect, that is selecting a different prognosis depending on how the information was obtained. And anchoring is that we give too much weightage to just one piece of information and then we go about it. So this is the advantage. So experience seem to improve prognostic accuracy, true, but the stronger the doctor-patient relationship, the lower the prognostic accuracy. So in this systemic review, here you can see the survival in palliative care, how accurate are clinicians and who are the experts. The black bar diagram shows the overall survival. Zero is the exact overall estimation. Right side, if you go, that is overestimation of survival. If you go to the left side, that is underestimation. So in this systemic review, you can see that most of the study shows towards the right. That is, the clinicians, we overestimate the survival. So is it correct? Overestimation? No, right? Because his care, goals of care will not be correct. The decision making regarding the treatment, the decision regarding related to end of life, that the decision making regarding the advance directive has to be timely. So we need to identify on timely basis rather than just experience based. So if how do we do that? We can take help of some statistical estimates of survival. These are certain tools which are helpful in obtaining a general prognosis using data and their outcomes. So Dr. Avinash Tiwari will be taking in detail regarding the tools in the next session. So what are the advantages here? Here, the advantage will be that they will eliminate some sort of cognitive biases. The disadvantage is that it is limited by availability and awareness. So we need to use this judicially, and we should have a practice that we should use these tools, not all the tools. We can just have one or two, and we can keep on practicing those so that it is easier for us to have a good prognosis. So if we talk about the prognostic factors, clinical prognostic factors in patients with advanced cancer according to consistency of evidence. If we talk about consistency of evidence, the first thing which comes in our mind is performance status. The second will be signs and symptoms of cancer, which are poor in prognosis and which are helpful in determining the prognosis. And similarly, some biological factors such as leukocytosis, lymphopenia, C-reactive protein, interleukin 10, interleukin 6. Next slide. So as I was telling you, the most important part, which is the performance status of all prognostic factor, this has been most extensively and consistently shown an association with survival duration. And in fact, most of the medical oncologists, radiation oncologists, palliative care physicians, they use it to a certain extent. The most common and widely used is the Eastern Cooperative Oncology Group. In short, we call that as ECOG scale. The other scales are Karnofsky performance status and the palliative performance scales. And the second point, which I just told you, was the prediction of survival and how important are the symptoms. Onset of various symptoms in association with poor survival in advanced care patient is important. They can complement the accuracy of performance status scores in accurately predicting the survival. For example, if a patient has brain metastasis, we know that yes, that is a poor prognostic. If the patient has recurrent ascites, these are the signs. But what about the important symptoms? Next slide. So important key symptoms which are predictive of survival are anorexia, xerostomia, weight loss, dysphagia, dyspnea, and these symptoms are widely used in the tools such as the palliative prognostic index and Karnofsky scales. So this will be again dealt later on. So these are important symptoms which we should keep in mind whenever we look at the patient and we see them clinically. Next slide. And if we talk about the biological parameters, a large number of laboratory abnormalities have been evaluated for the impact on survival. So what are these? These are hyponatremia, leukocytosis, lymphocytopenia, C-reactive protein, high levels of vitamin B12, high bilirubin level, the CRP ratios, the neutrophil to T lymphocyte ratios. These are the biological parameters which are now coming up and widely used to know the prognosis. So these were the important points which we need to remember. So what are the prognostic tools and models used in advanced cancer? So three very important tools which we routinely use in palliative care setting to know about the prognosis. These are the palliative prognostic scores, where they have many variables, such as they include the symptoms such as anorexia, dyspnea, leukocytosis, lymphopenia, and we have the Karnofsky performance scale. We have the second is the palliative prognostic index. Here, we categorize the patient into three groups. And if the prognosis is very poor, then we may say that the patient might live less than 4 weeks. If the scores are 4 to 6, we can say that the survival is 4 to 6 weeks. And if the scores are relatively fair, then we can say that the survival is greater than 6 weeks. So in this scale also, variables which are used are the palliative performance scale, dyspnea at rest, oral intake, and edema. So these scales, how do you need to how do you calculate the scores, and what are the survival benefits, and why is it important, will be taken in the next class. So next slide. So this was about foreseeing. Foreseeing means that you made a formulation of the prediction of the prognostication, right? Now the most important thing is how will you communicate the prognosis? This means foretelling. So we need to as Henry James told, that there are three things in human life which are very important. These things which you should do. The first is to be kind. The second again is to be kind, and the third thing is to be kind. Why? Because people do not really care how much you know. They really what they want is that they want you to know. They want you to know that how much you care for their patient. That is more important. So, for communicating the prognosis, there are few tools. One sort of tool is prepared. Prepared here means prepare for the discussion. We need to check the facts. We need to have an appropriate environment. Then we need to relate the person, develop rapport. We need to elicit patient and caregiver preferences. We need to provide information whatever we have. While providing information, we should use a simple language which is easy for them to understand, and whatever you want to tell them, they should be able to grasp that accordingly. We should acknowledge the emotions and concerns. There should be realistic hope. Unnecessary or false hope should not be given at these times. We need to encourage questions, and we need to document. And always important is to summarize whatever we have told them. The other tools which are very important here is the spikes. Here, spike stands for setting up the interview. Perception as perception, how much the patient knows. Then the I stands for invitation. Ask the patient how much they would like to know. K stands for knowledge. Provide information in small bits of pieces. Tackle the emotions, and again provide strategy and emotions. And for handling the emotions and empathy, the nurse mnemonic is very much important. So here, I'll just tell you the abbreviation: naming, understanding, respecting, supporting, and exploring the emotions whenever they come up. So these should be taken care of. So this on summarizing that the goal setting and maintenance of hope after disclosure of poor prognosis has to be very important. Before that, we need to identify the symptom. We need to manage that very much. We need to manage them appropriately, not only the physical, but also the emotional and other parameters, the social and the spiritual aspect. We should not promise any intervention that cannot be guaranteed. And we should discuss the quality of life, not the length of life. We should be prepared to discuss the death if the patients and their families are not interested. And very important, we should avoid abandonment. We should provide a plan that continues healthcare providers' involvement during the end of life. So, so I would conclude my talk by telling that prognostication is an art. It should be practiced by everyone. We should know what is the prognosis, that is we should foresee. We should have a predictive value using the tools, and once we know that this is the prognostication, we should communicate it properly. Why? Because if a good prognosis has been given, the patient will be involved in his goals of care, the plans will be formulated accordingly, he will be responsible for his management, and his quality of life will be good, not only his but his caregivers. Thank you so much. I end my slide by telling the power of healing does not lie in just prescribing drugs and medical treatment. What it essentially requires is caring for the patients. Thank you.
I would also like to introduce Dr. Anil Anand, sir. Sir has also joined us a little late, although sir is also the mentor for the same session. And sir is a senior director radiation oncology in Fortis Hospital, Gurgaon. So I would like to invite comments from Dr. Rakesh, Dr. Ankur, and Anil sir for the same.
So I think Dr. Puneet has covered very nicely the science of prognostication, because whenever we want to venture into the palliative care, for various reasons, first to understand the patient, then to understand the modalities of treatment, and then to provide the realistic goals we hope to the patient, it requires the understanding of prognostication from various aspects. And he's tried to divide it into two broad categories, and I'm sure that the next session will cover up those tools as well by Dr. Avinash Tiwari. And these tools need to be used very cautiously, but it has to be used, I can say, very profusely for all the patients, because they give the palliative care physician a clue that what is our planning should be there, what realistic hopes we can provide to the patients, and at what time we should change the modality of the intervention for these patients. So these prognostic tools will give you a very, you can say, a hint of how to go about in the journey of the patient itself and how to manage it. So he has nicely covered. I think we are open for the questions also if somebody wants to ask a question. Dr. Nayak has mentioned one comment here: how to bell the cat, how to detect cases where unethical curative treatment is being practiced unethically by oncologists. But I will put it this way, that if we understand the prognostication, I think we may not be labeled them as unethical. If we know the prognostication well, if we understand the prognostication well, if we bring into our clinical practice it well, and understand the basic principles of palliative care, I think we will provide the best possible care to all our patients. Dr. Anand is with us. He is radiation oncologist, and Dr. Bal, the medical oncologist. They can share their experiences.
Yeah.
How do they use radiation and prognostication?
So I think in this discussion, there are two things. Am I audible?
Yes, sir, you're audible.
Yeah. So there are two things involved. I think we are clubbing two things together. One is the palliative care, and the other is end of life care. Both are very different. The palliative care is that even on the day of diagnosis, patient may need a palliative pain control or dysphagia control or dyspnea control or other symptoms. So that is palliation. And for that, many people are involved. You people are involved, the palliative care specialists, the radiation, medical, surgical, anybody is involved. However, the end of life care or the prognostication is a absolutely different ball game, because that is a point which is kind of muzzled in our practice, I would say, that right now it is very difficult, or rather many times it is very confusing when to declare the patient is now end of life care, because one specialist may feel that it's end of life care, another may say, no, I can give some more palliative treatment, patient can go on for some more time. So I think if you read the literature about the prognostication and end of life care, first of all, we as physicians have to draw some line to know when we are going to start end of life care. And what I gather is that breaking the bad news is one of the most important factor, and for which none of us gets any formal training. So, you know, what happens if you see our junior colleague, they will say, okay, somebody may say it's very advanced, then nothing much can be done, very frankly, right on the face of the patient in 2 sentences, while it requires very careful handling. So I think this declaration of end of life or declaration of that this is now a palliative care situation, I think should be done by maybe a team of people initially, and then somebody can take over. But this is a very sensitive subject, and it can turn a patient into a a patient may not take it that lightly, because patient may feel that doctor was very blunt. He said nothing is possible. The disease has spread to brain, lung, liver. Now a few months. So compared to the somebody who is more experienced can do that. So I think this is my feeling that still in India, this breaking the bad news, etc., is taken in a very, I would say, rushed up manner. And while we require a very congenial sitting, very congenial talking, and then listening also to the patient, that is also very important. To what extent he or she wants to listen. We cannot just load her with the information and then patient suffers. So I think these are my comments on these. Yeah.
I will just put a small comment, sir. End of life is one of the small component of palliative care. It is a big spectrum. Yeah. So I'll not put it 2 spectrums, sir, 2 points. So palliative care starts from the day of diagnosis of any of the chronic disease, including the oncology setup. And I will put it a little more into it. It's just not the end of life care, but it also includes the bereavement, because it's finally the family who suffers.
So that's what I'm saying. It's very different. Palliative is very different from end of life.
Exactly. But it's just a spectrum, sir. It's just a spectrum, and all palliative care physicians are very well versed with it. I'll put it that it is not a very rocket science, sir. Puneet mentioned it very nicely. It just requires a human touch and basic understanding.
I don't agree. No, I don't agree. It is not simple.
I understand.
It is not simple. It is very sensitive, and very few people are trained in this. And many times I feel the patient is more traumatized knowing it rather than, So I feel the training is poor. We must know that treating the end of life, nobody wants to actually treat the end of life patient. That is also a problem. So I don't say that we are all very well trained. I don't agree.
This topic is prognostication, and prognostication is not only at end of life. We have to prognosticate at various stages.
That is different. That is prognostication is different. Prognosis is that you detect the cancer and then stage, and then that is different thing in which palliative care specialists may not be there in that meeting, because prognostication is the treating physician. However, when it comes to that patient is treated by several lines of treatment, and that is a prognosis that now it is end of treatment, specific treatment, and patient goes for palliative care. So things are very
Exactly, sir.
different.
Exactly, sir. This
Yeah.
is I'm telling that when there is some kind of a metastasis, when disease modifying treatment are reducing and symptom
Yeah.
management is required more,
Yeah.
we should start prognosticating and we should start giving realistic hope. This is what is required in palliative.
That's right. And I'm sure, as Dr. Rakesh said, this is no rocket science, but this can be learned. Communication, breaking bad news, these are the skills that people may not be born with, but these are the skills that the budding oncologists and every oncologist must learn, and these can be learned. Right? Thank you so much, sir, for your valuable comments. And I think we're already running late, so we'll quickly move on to the next session, which is about the prognostic tools in palliative medicine. And I would like to invite Dr. Deepak Gupta, who's a radiation oncologist from Medanta, to mentor this session. Dr. Deepak, yeah, he's here with us. So if you could just say hello.
Hello, good evening. Hi. Can you hear me?
Yes, we can.
Yeah, so now thank you for inviting me, Megha. So now we move on to the next session. Our next session will be done by Dr. Avinash, and he is a physician at AIMS Raipur, and he will be delivering his lecture. So there are other mentors also. Dr. Vedant is there, and also Dr. Gaurav Chana. Are these people are there?
Yes.
Yes.
Yeah, Dr. Deepak, I'm there, and Dr.
Hi,
Vedant.
sir.
Thank you.
Hi, sir. Good evening.
Hi, good evening.
Yes, good evening, everybody. And I'm really happy that there is a healthy debate about the topic. This means that we are moving ahead.
Yeah.
So we have
Avinash, you can start.
Thank you, sir, and thank you, Oncology Forum, for the opportunity. Can I start sharing my slides now?
Yes, you can start.
Are my slides visible? Moving?
It is not in full screen mode. You can see your slides.
I can see my slides. Is it moving?
No.
So can you share it from your side?
So you have to send it to me, or you can send it.
I have mailed you.
Yes, I'll do it. Thank you. Can you stop sharing?
Thank you, sir, for sharing the slides. So good evening, everyone. So the basic concept of prognostication has already been explained by Dr. Puneet, sir, and he has really well explained the aspects of prognostications and why the prognostication, not only the prognostication, the communication skills required following prognostication is very important. So, sir, next slide, please, sir. So what I will say, prognostication, not doing a proper prognostication is an inability to see beyond the moment, and that then can cause many distress to the patients and their relatives. Next slide, please. So classically, the prognostication tried something prognostication related to illness. What actually we were discussing the post presentation of Dr. Puneet sir. The prognostication related to illness, prognostication related to treatment, and prognostication related to person. So what would be the nature of the illness? What will be the stage and severity? What could be the extent of identification? What could be the speed of prognition? Or what would be the duration of illness? It is something prognostication related to illness. What could be the response to treatment? What could be the possible side effect or effect, benefit, risk? What could be the availability of expertise? It is like something, so previous slide, please. Or the treatment preference. So this is treatment related prognostication. And the factors which actually affect the personal prognostications are the age, gender, comorbidity, performance status, genetics factors, and personal choice. So this is known as prognostication triad. These are the factors also, and these are the domains of prognostication at individual level, at illness level, at treatment level, and personal level. Next slide, please, sir. So what we were discussing by the previous our experts, actually we have to differentiate between these two entities, the prognostication and the palliative prognostication. What in general we call is prognostication, and it is very dynamic. It changes from time to time when the patient diagnosed with cancer and when the patient having advanced cancer. So today's topic is basically prognostication tool in advanced cancer. So by default, that will be meaning the palliative prognostication. So in this, we deal with expected life expectancy so that we can make a proper decision making. Like overall prognostication, what we do in early stages of the cancer is basically about the overall health outcome. And the quality of life centric metrics are basically emphasized in palliative prognostication, and overall prognosticate basically has the disease centric metrics. So these are the basic difference. Taking consideration of this picture, we will move forward. Next slide, please. So what to prognosticate and what we as a healthcare professional are expected to prognosticate, and what are the prognostication and palliative prognostication, and what are the domains of prognostication, because depending on this definition, there will be different kind of tools. So we have to prognosticate life expectancy, we have to prognostication the behavior of the disease, the complication associated with disease, the complication associated with treatment, the prognostication of the symptoms or the trajectory of the symptoms, what would be the prognostication of further quality of life of patient, what could be the location of care, that is also one of the paradigm of prognostication, what could be the individual and functional status of the patient, and what could be the impact and financial status of the patient on the patient half and on the healthcare half. So this all we have to prognosticate. Next slide, please. So classically in our clinic, what we actually routinely use is to prognosticate is stage of the disease, performance status, previous clinical experience with the same kind of patients, and the knowledge of cancer trajectory, which is very important. That's why for the palliative medicine physician, the knowledge of the underlying disease is very important. However, all these parameters are subjective in nature, and that can be prognosticated. And as mentioned by Dr. Puneet, it can be most of the time over optimistic, because the bar diagram was lying on the right side of the graph. And next slide, please. Next slide, please. So what could be the end of the discussion? Probably a question will raise in everyone's mind: what could be the best model or tool which can actually prognosticate? So it is like I said, it is a very dynamic process. It depends upon the complexity of the situation, the subjectivity of the situation, and the clinical utility at that point of time. But we do have population related data. We do have functional status related inputs from the patient, which are the subjective parameters. And both the things overlap, and then we prognosticate. And there are certain confounding factors, or we can call prognostic indicators, which actually influence the overall prognostication. So this is the amalgam. There is no perfect tool, but a perfect tool will be which will have the amalgam of or integration of all these three basic domains of configuring a model or tool related to prognostication in advanced cancer. Next slide, please. So the prognostication in palliative care have basically two approaches, which are the non-disease specific and disease specific. Today we are talking about advanced cancer. So, but there are certain tools which are being used time to time and setting to setting in different geographical area, like palliative performance scale and palliative prognostication are actually used in various part of world in palliative care settings. But these are actually non-disease specific palliative prognostication. But certainly nowadays, the disease specific palliative prognostication, particularly in cancer, is very much popular. And what tool exactly we use is cancer prognostic scale and palliative prognostic scale, and some PIP scale and palliative performance palliative prognostic scale. So this is just to enumerate that there are certain disease specific palliative prognostication scale or tool, or certain non-disease specific scale or tool. Next slide, please, sir. So prognosis in cancer, if you talk about the, so I mentioned about the population related data, which are very much popular among the oncologists or the healthcare professional who work in oncology. So they talk about a graph, a curve, which is known as median survival. So like I have stated over here, the patient with metastatic lung cancer with non-small cell cancer having a median survival of 6 to 15 months. Isn't it important to prognosticate or to develop a tool which will actually incorporate such kind of information, which are very much evidence-based and which is very much data-based? So suppose a patient is having metastatic lung cancer with small non-small cell etiology, you can see here that the median survival is 6 to 15 months. Okay, so the cancer prognosis is already been prognosticated by the baseline data or the study which has been done previously. So we will talk about prognostic indicators in further side. Just to enumerate what is the importance of population-based data in modeling a prognostic tool. So this is this was the picture I used for the same. Next slide, please. So what could be the use of performance based? So the Venn diagram we saw last time in the previous slide was the having that two circle. One was the population, what the last slide was pertaining to that information only. And this slide is basically depicting the role of performance status or the functional status of the patient. Like there are different indicators which we use in our setting, like Karnofsky performance status and ECOG performance status. And you can see there are median survival mentioned. So this is, we have a population based data. Now we have prognostic indicator related data. Next slide, please. So this is palliative performance scale, which I just want you to focus on the prognosis in cancer median survival. Like I can see if there is palliative performance scale level is 60%, the pertaining prognosis in cancer is approximately 90 days. So this is showing how a performance status or functional status can also predict the prognosis. So it is not mandatory that we can use a multivariate model. The performance status and the population-based data can also suggest us very good prognostication regarding prognostication in advanced cancer patient. Next slide, please. So a formulation of prognostic tools, what conventionally we have seen over last 20 years in palliative care is basically clinical-based prognostication. There are certain model-based prognostication, and there are certain mixed kind which use clinician prediction of survival and also use certain multivariate or data-based scoring system or the nomograms, all the algorithm to incorporate. Basically, this scoring system incorporates various prognostic indicators, what we have actually seen in our previous slides. Next slide, please. So Dr. Puneet sir has excellently depicted the role of clinician prediction survival. Just to add in that, the clinician prediction of survival, where we actually most of the time over optimistic or overestimate, actually has the role with the experience of the clinician, but certainly it has certain association with the cancer type, genetic prognosis, what could be the condition at present of the patient, what are the symptom burdens and the associated psychological factor, comorbid factor, and what could be the individual prognosis. These all actually picturize in front of the clinician, and as per their experience and these values, clinician predicts a survival. So this is overall picture of a clinician prediction of survival. Next slide, please. Sorry. So model-based prognostication. So model-based prognostication actually incorporate in the different prognostic indicators who are actually disease-based, what we have mentioned in our previous slide, evidence-based and the population-based. So what I mentioned earlier, the best tool will be the amalgam of these three prognostication model. Next slide, please. And the model based on this prognostic indicator will be actually having more objective parameter. That's why it is actually preferred over clinician prediction of survival. So what are the our day-to-day clinical practice variables which actually has been incorporated in various prognostic tool in advanced cancers? There has been incorporation of the performance status, symptoms, basically the symptom what we actually see in ISAS, dyspnea, like is a very important symptom in palliative performance index. Delirium is also there, edema is also there. There are certain tools which use comorbidities as a prognostic tool. So certain psychological factors like depression, anxiety, quality of life health related tools, and there are certain laboratory values or the biological or genetic markers which also play a very important role in prognostication. Like in non-cancer, we use BNP in heart failure is a very important prognostic tool. Albumin level is very important prognostic indicator in cancer patients. So hypercalcemia has been established as a very important prognostic indicators in head and neck cancer patient. So these are the actually prognostic models. Different indicators have been merged, have been studies, and then we can see every year we come across a very new tool. So this is the model-based prognostic tool. Next slide, please. So coming to our first tool, which is known as palliative prognostic score, popularly known as PAP score. So this was first given by Maltoni et al. In 1999. This was basically used for the patients who have terminal stage malignancy, and the population he took was most of the population were at the end of life. There are different parameters like symptoms, anorexia, dyspnea, canopsy, performance status. And we can see over here, there is mention about clinical estimation of survival, hematological parameter like WBC and lymphocyte percentage. So you can find the palliative prognostic score in Google. But what I want to depict over here, it is very most widely validated palliative scoring system, but actually it relies on clinician estimate of survival. And what Dr. Puneet sir has mentioned that it actually overestimates. Okay. And considering the laboratory parameter near end of life, like some patient might have this parameter, some patient might not have this parameter. And doing a lab test is not very much encouraged in end of life until unless it has certain treatment related values. So the limitation of this story is basically the incorporation of the clinician estimate of survival and the laboratory values. Next slide, please. Basically, palliative prognostic score classify the prognosis or the population into three categories, A, B, and C, depending on the total score, which varies from 0 to 17.5. 0 to 5.5, 5.6 to 11, and 11.1 to 17.5. And actually, it shows the probability of 30-day survival. So actually, it depicts the probability, not actual survival. Next slide is about the palliative performance index, which is very popular nowadays because it is very feasible, because you can see the parameters are palliative performance scale, oral intake, edema, dyspnea at rest, and delirium, which are quite objective parameters. And it can be simple to administer. It is very much feasible, and it does not require lab investigations. That is the beauty about this tool. So I won't say this is the best tool. We should not mention in particular what is the best or which has the most coherence or most superior tool, but there should be a clinical utility of that tool. So it depends on patient to patient, and depends on setting to setting. So we are going to summarize all this tool in our last few slides. But to add on, this is a very good tool to predict survival less than 6 weeks. Okay, so the patients in which you are very confused with that what could be the survival more than less than 3 weeks or 6 weeks. So it is a very good tool to predict survival for less than 6 weeks. Next slide, please. So this is a novel tool which is known as prognosis in palliative care scale. There are two types of it depending on the incorporations of various factors, PIPS A and PIPS B. This was given by Guillaume et al. In 2011. So there are multiple prognostic indicators has been incorporated, and different indicators had different point. It is a very complex tool. the B part, the PIPS B part incorporates certain blood investigations. So that is one of the limitation about this tool. And also the A part has very much complexities. So it is not simple to administer, and at the point in certain settings, it is not also feasible. So overall, in a study done by Stone et al. In 2021, the PIPS is better than palliative performance index. There have been two large multi-center trial which has reported the superiority. So, but definitely the feasibility and the simplicity to administer is a issue in PIPS. Next slide, please. So the ASMO has come up with the recommendation in April 2023. This year only, say a patient with advanced care come to the which tool has to be used. If the patient's prognosis months and the patient is receiving disease modifying treatment, you can use simply with your experience and the performance status clinician prediction of survival. If the expected survival as per you is weeks to months and the patient is no longer receiving disease modified treatment, it is very much recommended to use PAP or PIPS B or PPI or FPN, that is fellow prognostic normogram. And depending on the clinical utility, you can choose any one of them. No one has been recommended over to another. And third is the prognosis of days or a patient is end of life. I think it is the ASMO recommends that it is better to use clinician prediction of survival, and in certain setting palliative performance scale can also be used. But this all has, they have also put certain comments on that start by asking about the type of information patient like to know, whether they want prognostication regarding the symptom or the life expectancy or the quality of life. Depending on that, you have to choose the tool. And whenever you prognosticate, you have to have that set of competency and skill to communicate what has been already mentioned by Dr. Rakesh Garg sir. So, and it is very important to learn those competencies. Next slide, please. So just to summarize, palliative performance scale or palliative prognostic score, that is popularly known as PAPS. So PPS has been used in both cancer and non-cancer across all palliative care setting, but PAPS has been used in hospital setting. PPS has been used, the key component, you can see over here, there's ambulation, the burden of the disease, self-care activities, intake and conscious level. But the PAPS scoring is having basically clinical prediction of survival, two laboratory values, breathless and anorexia. The strength of PPS is basically the predictivity of 1 week to 6 months, and the limitation is the ambiguity at mid-range is PPS score. Okay, so the mid-range, the scoring of mid-range PPS which lies between 10 to 30, the ambiguity or the homogeneity is not there in palliative performance scale. But in PAPS, the higher predictivity of 30-day mortality is very much likely as compared to PPS and PPI. So this is one of the strength of this this tool. And the practical utility is more or less same in both of the tool. But PAPS can be used in hospital setting, and PPS can be used in all the setting, even in community-based setting also. Next slide, please. Coming to the PPIs, and just to summarize, as I have also already mentioned, it is most feasible, simple to administer, contains objective parameter and does not require lab investigation. But this is only for cancer setting. You can see the components of PPS: oral intake, edema, breathlessness, address, and delirium. And delirium per se is a very individual good prognostic indicators of a poor prognosis. The beauty about PPI is its predictability for survival less than 6 weeks is better. And the limitation is its homogeneity or its predictivity in mixed typology of population, like different kind of malignancies. The practical utility is whenever you are predicting a survival less than 6 weeks with your clinician prediction of survival, I think PPI can be used at hospital setting. But if you're talking about community setting, PPS will be the best utility tool as per the research and the ASMO guidelines. I think we are done with the tools now. Thank you so much for your patience hearing. I'm very open to comments now.
Thank you, Dr. Avinash, for the nice detailed presentation. And but in palliative care, it is important to assess the prognosis of a patient because majority of things, even the best supportive care depends on how much the patient is about to survive. And nowadays, you have shown so many tools, but with the more molecular testing coming up, more and more mutation coming up, even the patients which are for palliative care are surviving long. So the tools probably maybe these are which you have shown it is 6 or 7 year old, some are 10 year old. Maybe this will modify over a period of time. So Dr. Vedam, your comment on this?
Yes, it's a very important topic which is not discussed very often.
Yeah.
And all of us have been doing it by clinical prediction only rather than by some objective measure, which is needed. And I think the best tool would be a combination of subjective as well as an objective parameter, but very simple to administer. You can't have a very detailed one because as oncologists, it will become very difficult for us to use on a regular basis. For a palliative care physician, it may still be okay, but I think for them also, the more concise, more precise, having maybe couple of subjective parameters and couple of objective parameters, and with a good validity should be used. And as has already been highlighted in previous session also, something very important, that we need to be kind and we need to understand and be sensitive to the needs more than actually providing the treatment in such situations. Because today, although palliative care actually begins from initial stages and until then, but today's topic is more of advanced cancer. So what patients need more in those settings is better understanding, better explanation, and also knowing that symptoms will be taken care of very well until the very end. Thank you.
So Dr. Gaurav, your comments now.
I think the topic was very precisely mentioned by Avinash, and we are yet to find an ideal solution to our problem. But I think we are on the right track, and like Dr. Vedant mentioned, the right solution would be a combination of both things, objective and subjective, and let us see where this journey takes us. And with the AI coming into picture, I think we would be able to find a solution to our problems.
So
Yeah,
because
I think Dr. Deepak, please go ahead.
well, this is most important thing in palliative care is to identify the patient, which patient are further suitable for treatment, and on the other hand, which is suitable for the best supportive care. Still, we are in the learning phase to identify the patient, because more and more drugs are coming, and which are actually improving the quality of life and the survival of the patient. So probably a lot of things yet to be learned. So it is actually less discussed topic, and it is important to discuss the palliative care also in each and every oncology part. Thank you, Dr. Avinash. Yeah, Dr. You want to?
Yes. Thank you so much, Avinash, first of all, for extensively covering this. Actually, Dr. Avinash has done his thesis on validation of PPI in Indian population, and he is soon publishing that. So I think we'll have one tool which is validated in our Indian setting. And so I think, so that's why, we need more validation here. We need more tools that are indigenously developed here. Let us see where we reach in this journey. And thank you so much. I think we'll quickly move on to our, and thank you so much, Dr. Deepak, Dr. Vedant, Dr. Gaurav, for mentoring this session.
Thank you.
Yeah. So we'll quickly move on to the last session for the day, which is, so we now all kind of know what is, for the PGs especially, what is the science of prognostication, what tools do we have, since this class is majorly for the PGs. So I hope that all the PGs have, sensitized by now that yes, prognostication is very important. Now we'll move on to a panel discussion where Dr. Ishita, who is a palliative medicine physician with CanSupport, will discuss clinical utilization of these tools, how the senior physicians have been using them, or how they intend to use it, and how to churn out from the senior physicians as to how we can go ahead and use these tools more often. Over to you, Dr. Okay, I'll just introduce our panelists as well, because I suppose maybe Dr. Ishita might not know them well. So Dr. Anjum, very dear senior, very sweet palliative care physician. She is a senior palliative physician in Bhagwan Mahavir Hospital, Jaipur. Dr. Geeta, she needs no introduction in this forum. Dr. Geeta is Senior Director, Breast Surgical Oncology in Max Vaishali PPG. Dr. Colonel Ranga Rao, again, he needs absolutely no introduction around here. He is, I think, Chief of Oncology in Paras Hospital, Gurgaon. And Dr. Dodul Mandal, a Senior Radiation Oncologist from Max Saket. Everybody, can you just say hello for our PGs and all the participants?
Hello, very nice to be here.
Hi.
Hi.
Hi, good evening, everyone.
Good evening.
Good evening.
Great. Thank you so much. And over to you, Ishita.
Thank you, Dr. Megha, and welcome panelists. I would just share my screen. So this is just a panel discussion, just a discussion of what we have already heard about, and now we should know from the experts what exactly is going on. Is my slide moving?
Yes, very well.
Okay, thank you. So first of all, this question goes out to all our panelists. How do you assess the prognosis in your clinical setting? We'll start with you, Dr. Anjum.
Thank you, Ishita. I think we need to also include in our prognostication skills conversation with the oncologist. So as a palliative care doctor, I will always talk to the referring oncologist and ask him or her where she thinks the patient is on his disease trajectory. And apart from the tools that Avinash and Puneet spoke about, we need to know, we understand that there's so much fluidity in the practice. Immunotherapy has changed goals entirely. We don't know now. Initially the prognosis that we were talking about to patients has changed now with genetic phenotypes and the introduction of immunotherapy. The other thing is each tool has its limitations, and we need to see like Avinash spoke so beautifully about population-based data and the performance data and the intersection of where the patient is on his disease trajectory. So it's a combination of your conversation with the oncologist, the Kaplan-Meier curve, where the patient is on the trajectory of disease, and which particular cancer he has.
Thank you, Dr. Anjum. Since you say that an oncologist's involvement is very important, I would like to ask the same question to Dr. Geeta. Ma'am, how do you assess the prognosis of a patient in your clinical setting?
I said, okay.
You're mute.
Thank you. Yeah. So I'm a surgical oncologist. So at the time that I see patients, and we are in a pretty good space when, of course, the decision is to operate. But of course, if you see primarily a patient who's come with advanced stage. So when I say advanced, I talk about locally advanced also. And then, of course, the metastatic setting. And if that is the case, you create a certain picture in your mind. It is basis the clinical stage as well as the subtype of the cancer, because I deal exclusively with breast cancer. So in my mind, I would have a thought to my mind, triple negative, locally advanced. I would think, oh, well. But I also think this is a discussion that I used to always have with Megha, but we never really got down to doing it. I think as clinicians, we're pretty bad with introducing our palliative care specialists to the care early on than later. It has to be my, I have to constantly remind myself that I have to do it. But what happens is if it is an advanced stage cancer, the moment the patient leaves my room, I kind of lose track of that patient, because now the patient is with my medical oncology colleague. And then, So the sensitization amongst clinical oncologists, all of us, I'm not saying a surgeon, I'm not absolving myself of the responsibility, but I think all of us need to be sensitized to the fact that, this patient at some point of time in her life is going to require the services of a supportive care physician. And the earlier you introduce that person into the picture, it becomes easy on the patient. So you have to remember that, when is the patient likely to be most receptive? I think the patient is going to be most receptive at the beginning of her journey, rather than at a time that she's losing the battle and you're trying to introduce a new physician and you don't even know what is the bandwidth of this person. How is this person going to be involved in your care? It's a tough time to explain it. So if you bring this person in early, I think you can change the dynamics around care. So I would look at it like that. So I know in my mind, I'm prognosticating the patient, but what am I doing to make it easier for the patient as she comes towards closure?
Thank you, Dr. Geeta. So I think we got a brief idea that prognostic tools are used, and there are various prognostic factors that are used for the prognosis of the patients. And as Dr. Geeta said, the prognosis also helps us to decide whether the patient requires palliative referral or not, which becomes important for the disease trajectory of the patient and for the continuum of care. So I will move on to my next question. What are the clinical tools for prognostication that you're using, if any? So Dr. Rangarao, this question is for you. Are you using any clinical tools for prognostication in your setting?
Very honest answer, no. We don't use any palliative. We have our own way of prognosticating a patient. I mean, let's say metastatic breast cancer comes. We will know exactly how long she's been suffering because we have been with her in her entire journey. After a surgeon like Dr. Geeta has operated upon, we take over, give adjuvant. Unfortunately, she may have a recurrence and has the metastasis. We go through the palliative care and then she still doesn't respond. We know that she's failing and then we keep telling her that, okay, you're failing, maybe you're ending for a palliative care thing. And then when she ultimately comes with a time where no anti-cancer therapy is possible, we prognosticate and then we have our own assessment. The rapidity of the advancement of the disease is one important clinical factor that we use. A patient may have taken years to progress to a palliative thing. Another patient may have taken a just a rapid 3 months, 2 months from the date of surgery. So we know how the biology of the disease is and how rapidly the patient is going downhill. So that is one of the important things. And then the treatment they have received, and then what treatments, what they were resistant to. So those are kind of things for the prognostication. So we prognosticate the patient according to the biology of the disease and the stage of the disease profile rather. So that's what we are doing, but we don't use the all the scores that you mentioned, PPI and all that, PAP score and all that. I mean, to me, they look a little complicated because I'm not a palliative care specialist, though we're dealing with it. They look a little, and I'm not sure of the practical application of these in a day-to-day practice. I mean, if you keep doing the scoring and then, then I'm not sure of that. It's simply because of my ignorance of using these practices. I mean, that's the reason. I hope that is good enough.
Thank you. Thank you, sir. Dr. Mondal, are you using any tools for prognostication?
So I'll be honest, like Dr. Rangarao told you that we do not actually use any specific palliative care prognostic tools. But of course, yes, there are certain clinical things which we use to understand the patient's condition and then the expected tolerance to our proposed treatment and the toxicity. Like one of the most important thing we many a time forget is about the nutritional condition of the patient. There are certain index and indices to assess how to evaluate a nutritional condition of a patient. I'm not going to those details, but there are a lot of index for that. Now, other things are like there are different clinical investigational lab results, like a very low albumin, very high calcium in a squamous cell carcinoma patient of lung cancer, So we know that they are not going to make it for a long time. And of course, performance status, like either it's ECOG performance status or Karnofsky performance status, that we regularly use on a day-to-day basis to understand whether the patient is going to make it. So Dr. Anjum began her talk actually with immunotherapy. So I think that's a very good message that the clinical care, the treatment landscape, and the outcome has grossly changed and significantly changed over the last 1 decade. So what we initially considered as incurable and considered as end of life care probably may not hold true in today's time. One more thing which we do not take into account is financial toxicity. So same treatment, if a patient is unable to afford, but if that is the only treatment which is going to give a meaningful difference, but because of financial things, the patient is unable to accept that treatment or afford the treatment, of course, that also we need to take into account in a clinical decision making. So I think these are all clinical things which we discuss and we take into account, but very honestly, none of these palliative care indexes we are using on a daily basis.
Thank you, Dr. Mandal. So I think, Dr. Mandal, you are using a few tools, but not the prognostication tools that we've just talked about. Dr. Avinash had very nicely summed up this particular slide. I would not go in detail for this, but this discussion that we just had with Dr. Rangarao and Dr. Mandal did stir up a question. Prognostic tools or clinical predictions, which are better in palliative care? We now know what is being done, but what do you think is better? Dr. Anjum?
So I think the tools definitely help, and we are using PPS. And Colonel Rangarao and Dr. Mondal are using performance status. So PPS is a more, should I say, more detailed PPS, more detailed KPS or ECOG. It goes into a little bit more detail, and it's purely clinical, no tests, no blood tests, and extremely, I think it's fairly accurate. So the other thing was, when someone is as senior as Colonel Rangarao, he has these years of experience to go on clinical estimation of prediction of survival. Someone who's new in medical oncology or in oncology or palliative care will not have that experience to guide him. So the tools will probably help you when you're in your early phase of a career, because even Christakis and Paul Glare, his study said that people who were experienced had better prediction. So I think when you're finding your feet, maybe then the tools will help more and they'll guide you more. And then as you get more experience, maybe you'll rely more on your clinic experience. And like I think Dr. Mandal also said, certain symptoms are markers of advancing disease, like dyspnea, like delirium, like anorexic cachexia syndrome, and like depression. So these are markers of a short lifespan. So apart from the tool, definitely clinical experience and clinical symptoms will change the
Thank you, Dr. Anjum. So
accuracy.
Dr. Rangarao, do you agree that clinical predictions do come with experience, and prognostic tools should be considered?
Yeah, fine. So let me tell you about the younger generation. About the palliative care may have multiple scores. Okay, agreed. They have in metastatic renal cancer, metastatic lung cancer, and ovarian cancer, everywhere there is a scoring system, including lymphoma, everywhere. Let me honestly tell that none of the students use any of these tools in the routine practice. They'll say NHL stage 3 or 4, and then they'll say, okay, IPI index, hardly any even senior consultants use it. All right. And then what is the practical utility of IPI index? I'm just giving an example that so many scoring systems are existing in this clinical world, and then through the journey that we're going through, that it is impossible to put them into the practice. And then ultimately, if you do it, how much practical difference does it make? That's a key question. Because if we have understood the whole patient's journey and the biology, we know that, okay, an obstructive jaundice, he's going to, he's already going to hepatic coma. We know it's a matter of time. We really don't require any score to apply to him. And then similarly, in esophageal cancer who is cachexic or a breast cancer who is completely gone beyond all the treatment, and then we know exactly the patient where the patient is heading. So you and then these predictions may give some kind of a prognosis, but they don't change the outline of management. If the albumin is low, its prognosis is bad, but all you do is correct nutrition. May not give IV albumin, but you just correct the nutrition. So that's a solution. So to me, I think the clinical, most of the people, these will be there for a theory paper in the answer or in a discussion like this. But ultimately, when it comes to the practical utility and then practical application, I'll be very blunt and honest that it's nearly impossible. We don't think of the scoring in that patient. We just have the clinical situation. Okay, give him this. Let's do this for this patient. Let's relieve this symptom. That's how the mind works in the clinic.
Thank you, Dr. Rangarao. Dr. Geeta, would you like to add something?
So just curious, I just, because you put clinical prediction versus prognostic tools, is there anything to, have you worked on the concordance of these two? How, comparing clinical prediction with prognostic tools, do they match up? If they do, then I think, it is easier to clinically predict. I'm not trying to run the palliative care physicians' efforts down, but I think by and large, if there is good concordance between what the clinician thinks and what the palliative care physician comes up with after putting the tool to test, I think, then, the clinician does have an edge in the sense, because, the interactions by and large of a patient who is kind of exhausting all her options will remain with the primary physician. In fact, we also get relegated to the background by then because, but where I think is the problem is, when do you stop? That is what needs more focus, because what happens is, it is okay to prognosticate. There will be patients and patients attendants who say, even if there is a 1% chance, I want to do it, I want to give it all. And then all these molecules that are available now to the medical oncologists with a new molecule coming up as we speak, so there are too many options available, and those who can afford it will say, "Karo, jo bhi karna hai karo," because I don't want to think about what you're trying to tell me. So there are people who are not receptive to what you're trying to say, even if you show them a tool and a score and whatever it is. But I do understand. I completely get what Colonel Rangarao is trying to say. That as clinicians, your job is to sit on that chair and convey to them exactly what you think. And if a palliative care physician is around and is already in the picture, like I said, you bring them in earlier, then you can give more, kind of concreteness to whatever is being said. So I think that is where the palliative care physician will become important and these tools become important. But I completely agree. I think a clinician does have a feel on the pulse. A clinician does know which way the patient is going. But I'm not saying that we should not seek your help. Because for me, when the patient is going that way, you have to focus on only 3 things, which is something that I constantly think, and that is nutrition, pain, and sleep. These are the 3 things that would make the patient comfortable, and that is where the focus should be.
Thank you, Dr. Geeta. Dr. Anjum, you want to add something?
I was just wanting to answer, not argue with Colonel Rangarao, but put an alternative viewpoint in the sense that when you have, maybe you're moving in the direction that America is going, and after a certain time, we'll have insurance policies and hospices asking for specific criteria to be met before the patient can benefit from Mediclaim or hospice policies or whatever. So in that, I'm sure, and they're not likely to go purely by clinical prediction. They probably ask more strict criteria based on tests or on investigations. So we're not there yet, but maybe then at that stage, the clinical prediction of survival may not be given as much weightage as we are giving today.
So while I'd like to respond to that, so Dr. Anjum, I do understand, this objectivity business sometimes get to be too claustrophobic for the patient. That is where, how you've handled the patient through the journey. There are some things that the patient wants to hear only from you, only from this person who has been there through her journey, has seen all the ups and downs and everything, the highs and the lows. So while there has to be maturity on the part of the clinician, there has to be maturity on the part of the people who are receiving it. So in a country like ours, it is tough because in America it would work because both the recipient and the person who's actually conveying this are pretty much aligned. But in our situation, we Doc Saab, aap jaisa bolte ho. Abhi bhi, it works like that. Aap jaisa bologe, hai na? So I think we're kind of 50 years, if not more, before we get to that point when they say, oh, show me this objectivity and show me the score and where do I stand, and then I'll take a decision. But it's a great thought. And your tribe is growing in strength. I'm very happy for that. And I think there have to be more like you. And no oncology program should be complete without your presence. Because like I said, the conviction will only grow when you come in and pitch in earlier than later.
Thank you, Dr.
Vedant, I think Dr. Vedant wants to.
Yes, Dr. Vedant, would you like to add something, sir? So your hand was raised.
Sorry, I was muted. So yeah,
Yes.
it was interesting. It's true, as Dr. Anjum said, that, when America moves one way, everybody moves that way. But unfortunately, most of the time, Americans are moving the wrong way. And and I also agree with Dr. Geeta that, we usually have a hang of it, and going into too much of objectivity at that stage of life becomes a bit difficult for the patient also. So we have to have a good balance of the things. Thank you.
Can I add a couple of things? I mean, I think Geeta asked a very good question, whether there's a validation of prognostic tool versus clinical predictions. Clinical predictions vary from patient to patient. A cholangiocarcinoma patient with a complete and exhausted every treatment is totally different from a metastatic breast cancer who's also exhausted in a slowly growing tumor like a metastatic breast cancer over the years, she'll take a long time. And then I'm not sure the utility of a prognostic score because it is palliative care medicine is totally different from patient to patient. I'm sure you will agree. Here we have a metastatic breast cancer, metastatic lung cancer. Somebody is fast growing, somebody is slowly growing, entirely different. I am a little skeptical about the application of these kind of prognostic tools in a given patient because the biology is so different. The prognosis ultimately depends on the biology of the disease. We have seen a patient, recently seen a metastatic cholangiocarcinoma who went into obstructive jaundice. He couldn't be stented, and then we sent him to another specialist for the stenting. He did the stenting. Once he comes back, you can't imagine that he had a problem like that. It's totally different. So I would bet upon the clinical predictions more than the prognostic tools, simply because I have not been exposed to the prognostic tools. That's the ignorance I would completely claim that, okay, I have not been exposed. And even if I learn about them, I am unsure of their clinical practice in every patient. Every patient is so different. So that is one important thing. And something more, I think Geeta was also saying, I think in the palliative care medicine, we have exhausted all the anti-cancer medications irrespective of the options available. Here, we are not asking the question what to do. We are just asking the question how to palliate. So I think with palliation, so whether you do the taps to relieve the dyspnea, whether you're giving a LASIK, whatever, what you're doing symptomatic treatment, we are not here putting in the question what anti-cancer treatment, what TKI to give. No way. So that is the second thing. Third thing is the American. You said a very good statement that yes, America. Let me tell you, NCCN guidelines are not practiced by the Americans most of the times. They are only for the insurance purposes, so that the insurance sees that, okay, it's listed, then they'll pass the claim, otherwise not. And then they, you talk to anyone, whenever you go to the conference anywhere abroad or in India, they are from the big institutes. We ask them, what about the NCCN guidelines? He says, that's not meant for us. We don't follow, we have our own guidelines. Similarly, the palliative care, the places where I've been visiting, I won't say many of them, but 3-4 major institutes wherever I visited, most of the IPD is consisting of the palliative care patients. And it is not that, and then only those who are really dying, the patient is given an option, would you like to move to hospice? Let me tell you, even the Americans are not happy to move to hospice. And if you go to hospice and see, and they have patients, I mean, I've been to some hospices, and they have their patients, their daycare hospices. The patients leave them in the hospice because they can't take care of them in the daytime. It's something like a daycare child care. So daycare, old care, that is what is there. So and then I don't think the hospice and the that kind of thing is very successful even in a state like in a country like US. So I don't think we are anything different from them, and the direction which we are moving is not bad. And as I said, it's not necessarily they are moving in the right direction. We are not moving, and I think it takes time to get even an appointment for an ultrasound for a pregnant lady. And a fracture is not an emergency. They have to wait for 6 weeks. If that is the American system that we are going to go to, definitely I would not like to land up into that situation. An MRI appointment takes, ages. I mean, these are just the examples. So I don't think we should blindly follow just because the Americans or Britishers do. Yeah. So I would say that. And then these prognostic tools are very good. I'm not doubting their importance. They're in certain places, definitely they'll be useful to how to predict what to do next and all that. They'll be useful, I'm sure. Only my ignorance, stops me saying that, okay, I've used it and I find it better.
Thank you, Colonel Rangarao. Dr. Sushma, you want to add something?
Yes, I want to add something. Hello,
Thank you,
Dr. Megha. How are you? Hello, Dr. and everyone. Gita. Actually, there is no
Ma'am, your voice is frozen. Ma'am, your there's some connection error, ma'am.
Final authority based on our experience. Can you hear? Can you hear me now? I have removed the iPhones.
Yes, ma'am.
Yes, ma'am. Okay. So I was just telling the clinical prediction will always remain the number one prediction, and based on our experience, what we say to the patient, based on the experience of having patients since last many years, knowing patient many years, and based on our findings, I think there is no comparison. But having a single prognostic tool in day-to-day practice will make our practice more systematic. We will be able to generate data. And it is always a good habit having a single prognostic tool, which is very short, which is very easily usable, and then comparing it, because during our rounds, what we do, our residents say that palliative prognostication score is like this, and then immediately we compare that clinically patient is doing quite well, so or patient is same what prediction score is saying. So it is a good habit of having with the students. If I think we talk this class is for the students, I think we should convey this message that clinical prediction will always remain number one based on your experience, but having a single prognostic tool in day-to-day practice is going to be very useful, ultimately in terms of generating data, ultimately in terms of connecting with the Dr. Geeta has said that how much we have validated. So we will validate only when we will use that, okay, this works. And one more thing which Dr. Rangarao is saying is absolutely right, that rather than using all the prognostication scores from waste, I think we can create our own scores. And it is not that human being will remain same in America, in England, and in India, but ultimately there are many things which we can do differently in India. So this is right time that palliative care community now is growing. We should create some very easy to use scores for in day-to-day practice, so that we can integrate this tool into our clinical practice. Thank you.
Thank you, ma'am. Thank you so much. So on that note, On that note, I would like to have the next question, that prognostication in the last days of life and the associated scoring tools. Dr. Anjum, if you can help us with the discussion.
Yeah, so there are several tools. Sorry, Dr. Rangarao. There are tools. There are more tools. There's still more tools. So, I mean, so your points are all well taken, and all our tools work in the last 6 months. So that's a horizon effect, and they're all accurate towards the end, not accurate in the beginning where you all rule the roost. All our tools are more accurate towards the last 6 months, last year and last 6 months, especially in cancer. There are some, there's a recent research in 2022 by from MD Anderson and Japan, which predict the last few days of survival. So they all based on clinical criteria like the death rattle and the inability to close the eye, noisy breathing, loss of the radial pulse. But they're very useful for us in palliative care, in hospice, and in death certifying and preparing the family for death. May not be so relevant for you all in oncology practice.
Thank you, Dr. Anjum. So you had earlier also shared this paper from, by Omori and Morita. So I have quoted that here as well. So we did, as Dr. Sushma said, that clinical prediction does remain #1, but including the prognostic indicators, including the prognostic tools, help us make it better. So how can we make prognostic indicators more inclusive in our practice? Dr. Mandal?
Yeah, very practical question, because as of now, we are not using it on a regular basis in our day-to-day clinical practice. And then, so probably making it a part of research work as thesis will be a good idea, where we can have a collaboration between the clinical department and the palliative care department as well. And of course, then comparing this outcome between our clinical parameters and the palliative parameters or the palliative care indices. So probably that will give some more ideas whether they're actually corroborating or not, and whether they can be made more inclusive in our daily practices.
Thank you, Dr. Mandal. Dr. Geeta, would you also share some ideas? How can we make these prognostic indicators more inclusive in our practice?
If you ask me, if you're trying to get the clinicians to use these tools, I don't think it is going to happen. So like I said, the only way to integrate it is, possibly, just as you have your e-prescription, on your e-prescription, there have to be the.
Ma'am, we are not able to hear you.
Just a second. Okay.
Can you hear me now?
Yes, ma'am. Much better.
Yeah. So I was saying that if you're wanting the clinicians to, try and do this prognostic tool thing, I don't think it is going to happen. The only way I think, practically what we can do is, you have these e-prescriptions. So there can be another column where you can possibly have 2 or 3 questions. And the moment you enter it, it goes to the palliative care physician saying there is it flags up on the palliative care physician's laptop. Okay, look, this patient, this is what the clinician thinks, or whatever tool, those 2 questions answered by the clinician, this is what it is. And from that point of time, the palliative care physician has to take more. Because I don't think it is possible for any clinician, because there's too much on the plate already. We're trying to double up as psychologists, as fertility experts, as genetics persons. So, trying to get the palliative piece also onto the clinician's table is going to make the task difficult. But like I said, if there are those 2 questions, which says, if both questions are yes, then, you need a palliative, or maybe 3 questions. If all 3 are yes, then you need a palliative care physician in your care. If it is only 1 question, then you don't, or whatever, something like that. So you have to score the clinician's inclination actually before anything else. Otherwise, it's going to be tough. The integration has to happen at that level, I would think.
Thank you, Dr. Geeta. Dr. Dr. Ranga sir, would you want to?
Right. So I think it will be a good idea to include these prognostic indicators in the clinical practice, provided they have that inclination, because as Geeta has said, they have already too much on their plate to have this also. So I think that calls for one important thing: integration of the palliative care medicine into every cancer center, so that these people can participate in the palliative care from the day one, and then they are always in the team, so that the patient doesn't feel the person who's going to take care of them in future is any different from the current team. Because if a new person walks in at the time of the palliative care, I think we are defeating the very purpose of the palliative care. So the patient has to be, even if the patient is undergoing the anti-cancer therapy, it doesn't matter. So the palliative care specialist has to be there, and then his help or her help will be very, very valuable in prognosticating this patient, and then taking the decisions whether to go for ventilation. I mean, there are many situations where we we have to take decisions. So I think these kind of wherever the turning point is, the important thing is to turn right or left. I think these prognostic indicators may come into play. So one important thing is to train the medical oncologist how to use them and how useful they are. If he's convinced of their utility, I'm sure he will learn and start doing it. One. And second thing is incorporation of the palliative care specialist right from the beginning in every cancer center. Somehow, if some kind of a ruling is made that, okay, if the cancer center should have a radiotherapy machine, also a palliative care specialist. They should have a surgical oncologist, also a palliative care specialist. If they make it as important as that, I think their things will be better.
Thank you, sir. Dr. Sushma ma'am, you.
But I was telling the same thing, Dr. Ranga and Dr. Geeta, what you have said, that just in brief, that two things will happen, that if a smallest 2 or 3 parameters, which definitely we will create for all the oncologists, it will be there in the day-to-day practice, it will be a habit, it will become a habit. Otherwise, it is right that oncologist and everybody is so busy that if we will say that please fill up this form also and this is indicator also, it will be tough. So if there are 2-3 indicators, this will also be helpful to transit, because transition of care is always tough. It is always a gray area. If we will have these through the 2 or 3 markers, which we will say that this is governing, that we should now this to transit in this different phase, minimum disease directed therapy or no disease directed therapy. I think there are initially it is only disease directed therapy, then minimal disease directed therapy, and then no disease directed. I think this will help us in ruling out this gray zone also, because in oncology there are always a lot of gray zones, and it is really becoming it becomes difficult. Simultaneously, we should never forget communication is most important. Whatever you do, whatever indicators you will use, your clinical skills and communication will rule everything. So we should always take care of this, that how you are using your communication skills and your clinical skills. Thank you.
Thank you, ma'am. So to summarize, we should start using the prognostic indicators. We should train ourselves to use them. And of course, we should base it on research. But let's just start. Thank you.
So what I'll suggest with this class, that definitely within 1 month or 2 months, we should come out with a very easy to use indicators for oncologists in day-to-day practice, so that they will start using it, and then this will start governing. I think Anjum, we can do it. We are using it, but we have to be very focused and very crisp that what exactly we want to convey to integrate these tools in oncology practice.
Thank you, ma'am. Over to you, Dr. Megha.
Thank you so much. It was so overwhelming to hear everybody's responses, and I'm very happy for this engaging panel discussion and everybody's responses. I think yes. So this is a clinical prediction has always been there, and for someone as senior as Dr. Ranga Rao, I mean, his clinical prediction would definitely be as correct as any other the tools that we might use. So, but again, as Dr. Anjum rightly said, that especially for, who are budding oncologists, for the PGs, and for, those who are starting their practice, I think using certain objective ways would go a long way in their practice, and how to, in their prognostication skills, right? 2-3 points I think that I felt were very important, and I would like to re-emphasize them, is what Dr. Anjum said first, that before any palliative care physician prognosticates a patient, discussing with the referring oncologist is very, very important. For all the palliative medicine physicians, I would like to re-emphasize this. We do this in our practice daily. So it's very important to have their perspective with the increasing amount of, these advanced therapies and targeted therapies coming in. It's very important for all of us. Another thing about prognostication, introducing it at the right time, as Dr. Anjum again said, at the right time. Most importantly, the right time would probably be when there is a change if there's a bend in the trajectory, right? When the goal changes from cure to care, when there is a progression while on chemotherapy, while on therapy. So that would be an important point where we can introduce, even while the patient is on some second line, third line therapies. So that would be, I think, a good transition point to, introduce the concept of palliation to the patient, and have a word with the palliative care physician, even if the patient is not very symptomatic at that time. A good point to introduce. And yeah, I think also Dr. Mandal said a little bit about financial toxicity that must be taken into consideration. And I think the recent concept of time toxicity must also be taken into consideration, inclusive of the goals of the patients and their caregivers. And so I think time toxicity is also something that is less talked about when we are prognosticating, or probably, telling about the options of disease-directed therapies that are available. Yeah. These are certain important points that I could notice. And I would like to, any last words from very senior people? We have everyone around. Any last words from anyone who would like to say something?
Excellent session. I think I go more educated than before about the palliative care integration. I think we should have, only thing is the palliative care specialist should not walk in the last moment. He or she should be coming right in the beginning of a metastatic patient, so that the patient accepts them and continues the care.
Absolutely. Thank you so much, everyone. And very senior people who could make it for the session. I would like to thank them from the deepest corner of my heart to take out time in this evening from their family time. Thank you so much, everyone. And thank you all the attendees who could come for this session. Thank you.
Thank you. Good night. Good night, everyone.
Good night. Good night, everyone.
Thank you and good night. Thank you for having me.
Thank you, Nidhi, for organizing it very well. Thank you.
And thank you, Dr. Megha, for creating such a comprehensive class, a good discussion, a very healthy discussion. It was very informative. Thank you so much.
Thank you,
everyone. Good night.
Good night. Bye-bye.
Thanks, Geeta. Bye.